Madi.
We'll finish prayer and all till madam comes.
Yeah, by then. Okay. Good evening, everyone. Today we are having a very important meeting about male infertility, where we are having case discussions. As we all know, 50% of the cases are because of the male factor, and exclusive male infertility can be seen in about 20% of the patients in our infertility practice. So we have a very eminent speaker, very senior IVF specialist, Dr. Abha Majumdar, with us today to present us all the case scenarios and how to manage. Madam, Dr. Shobha Gudi, ma'am, would you like to say a few words?
Yeah, I would like to. Yeah, I would like to. Arun to first play the prayer song.
Okay, ma'am.
Yeah,
Arun,
Rajeshri madam
prayer.
has also joined. Rajeshri madam also joined.
Yeah.
Good evening, madam.
Good
Yeah.
evening.
Welcome, Rajeshri. Welcome.
Good evening.
Good
Welcome,
evening.
madam.
Good evening.
Good evening, Rajeshri madam.
Good evening, everybody.
Prayer, please. Good evening, everyone, and a very warm welcome to this webinar on infertility. Now, the Committee of Infertility and Reproductive Medicine in Kasoga really deserves to be complimented and encouraged, because this is a very complex subject for everyday practice. And Dr. Shilpa, Dr. Vidya, and the entire team have made every effort to bring in, so many capsules of knowledge for us. Time and again, they are also publishing their advances, etc., every few days. So I congratulate both of you and your team for bringing in, especially today's program. And I welcome Dr. Abha Majumdar to Kasoga webinar. Welcome, madam, and it's really lovely to see you coming and speaking for us. Thank you for being here. And I hand over to Dr. Rajesh Paladi, the president. Okay?
Yes, ma'am.
Namaste. Good evening, everybody.
Good evening,
I would
ma'am.
like to congratulate Dr. Shilpa and Dr. Vidya for taking up the scheduled webinars, the weekly webinars that we have conducting. And this will help us to understand better in a streamlined manner as to how we can deal with the subjects or topics of interest. And very few names, many names in the field of infertility strike out, and one such is Abha Muzumdar. Madam, welcome to Kasoga, and thanks for accepting our invitation. And also Dr. Anuradha Khar, who is a well-known figure in the field of fertility and the secretary of the KISAR in Karnataka. Dr. Abha, we have been doing the weekly webinars. We have 12 committees in Kasoga, and each Wednesday we have a webinar with a focused topic, so that it helps us to, streamline, and the consultants to take up very meaningful understanding. Nowadays, we are so much bombarded with the webinars and teaching which is happening everywhere. So our attempt is to make it very strong and useful for the clinical practitioners as to how to deal with it. And I'm very happy that Shilpa has chosen very good topics. And I'm sure that the audience and the delegates who have logged in, about 45 now, will definitely benefit with the interactions which go on in this platform. Best wishes, and thank you for accepting our invitation. And Shilpa, I think you could go ahead with this program without much ado.
Thank you, ma'am. Thank you.
Yeah.
So, Dr. Vidya, I would want you to introduce Dr. Abha Majumdar and then to proceed with the program.
Can I get slides?
Yeah.
Dr. Abha, my beloved teacher, and my really, I respect her too much from when I started my practice. She is a Emirates consultant advisor, Center of IVF in Human Reproduction, course director, and course director for Fellowship of Reproductive medicine at Gangaram Hospital. She is pioneer in IVF in North India, practicing over 40 years. She is a member, past president of IFS, 7 gold medals, president silver medals, uh, chancellor's medals, medical graduate in 1970-75 SN Medical College, Agra. She got Abdul Kalam Gold Medal 2015, Rashtriya Gaurav Gold Medal 2017, Bharat Ratna Rajiv Gandhi Gold Medal 23, Distinguished Teacher of Excellence Award by NB 2017, IVF Champion of the Year for successively 3 years, Lifetime Achievement Award by OBG Society, IFS 2021, and JK Jammu Kashmir Society. 50, she has published 50 original articles and case reports in Index General, and she is excellent teacher. And whenever you feel any problem in infertility, she is available for each and every student. Thank you, madam. Thank you, madam, for being with us.
Thank you so much. So, do I share my slides now?
Yes, madam.
Yes, ma'am.
Can you see my slide? Can you see my slide?
Yes, ma'am.
Okay. So I'm going to start. I was told that there would be a lot of gynecologists also in this symposium or in this webinar. So I thought, let me take questions which we as gynecologists should know about male fertility. Now, male infertility, what is our single point diagnosis? All of you think, when do you think there is a male problem? On abnormal semen analysis. So this is our first point. We don't examine the males. We don't ask much history except smoking, diabetes, obesity. So one abnormal semen analysis and you start thinking that there is a male factor. So what do we do next? A little bit about the history of how semen analysis is determined and what are the cutoffs. The first manual was made in 1980 by WHO, then 87, then 92, 99, and 2010. Till almost 20 years, 2010 to 2020, we continued to use the 2010 manual reference points. But in 21, WHO laboratory manual for human semen was changed. And these are the changed ones. I just want you to know this, maybe take a picture of this so that you know what has changed from 2010 to 2021. Can we have everyone silenced, please? So if you see, there are very slight changes, like slight decrease in volume, slight increase in sperm concentration. Total number of sperm remain unchanged because the volume has gone down. Total motility, very slight increase from 40 to 42. Progressive motility from 32 to 30. Sperm vitality is decreased from 58 to 54, also is considered normal. And 4%, more than 4% remains normal sperm morphology. Please remember these figures because I'm going to have a MCQ for all of us, all of you later on. So these are the general questions. That is there any effect of duration of abstinence before I ask my husband or I go for a semen testing? Then how do you as a gynecologist evaluate abnormal semen analysis report? How to assess two laboratories, different reports, and how to identify the correct report? How to proceed if azoospermia is there in the first semen analysis, and when do you need to refer? What to suspect if semen volume is very low? When do you suggest donor insemination at your level? And ultrasound diagnosis of varicocele with subnormal semen, what do you do? What do you tell the patient? When do you refer them to a urologist or to a ART specialist? I'll come with all these answers. And last is there any role of antioxidants in treating low semen parameters in infertile men? Having said that, we'll come to the first case. Normal female partner, mildly abnormal husband semen analysis after 10 days of abstinence. What is the next step? Now, is there any importance of lesser or longer durations of abstinence? Now, this is a very important point because constantly. This is a very important point because you find half infertile people have not had sex for 10 days or maybe for a whole month or maybe 15 days. And then when you ask them to go and give a semen for analysis, they go and give it right away. So ideal window of abstinence, we all know WHO recommends 2 to 7 days prior to test. Uh, However, most of the modern fertility clinics and specialists say a window of 2 to 5 is also good. But then there are important nuances to this. Too long can be counterproductive. Abstaining for more than 7 days can actually lower sperm motility, increase DNA fragmentation due to sperm cells being exposed to oxidative stress while waiting to be released. And testing for procedures. Now, suppose you want to do IVF or IUI and you want to prepare the semen for one of these procedures. Some recent studies recommend a very short abstinence period of under 24 hours to achieve optimal functional quality, motility, and vitality of sperms. Now, here the volume doesn't matter. Say, if the person has ejaculated 14 or 18 hours before and you ask him to give a sample for IUI, it will only reduce the volume marginally, but when you concentrate it into zero point 0.4 ml of liquid which is handed over for IUI, then the vitality, quality, motility remains same. So please remember 2 to 7 days is suggested by WHO, but we are following, a lot of us do 2 to 5 days. When the abstinence is long, then it can lower the sperm quality. Next case comes case number 2. How to evaluate abnormal semen analysis report. And you get from 2 labs, 2 different reports, how to identify the correct report. And as we all know, semen analysis is the first and generally the only test done to detect male infertility. So I'll show you few samples of semen reports. How will you find which one is most reliable? Like here you see this report from a very good clinic. Then you see another report here. Then you see a hand report here. And you see one report here. What do you find which strikes you most is the morphology. It is 6% here. Here it is normal. What does normal morphology mean? I don't understand. Here it is 80%. Can you think that the technician knows to see morphology? So if we see, this is a continuation of the same report. So this is how. Another sample, again, you look at the morphology. These are nice famous labs. But if you see morphology is 80% normal, 50% normal, so you know that, you don't even know whether they've used a counting chamber, whether it's new bar or something else for the sperm count. So if there are lots of sperms, anything can be written. So today, CASA becomes the standard, and the newer models, the newer module also tells us morphology. Though there is a difference between manual and CASA, but at least we will not get such variegated reports about morphology like it is here. Another report is again here, and you see 2% morphology, and here it is 52% morphology. Same patient. So you cannot imagine that what would you take as normal should be normal for the patient. So I always identify the knowledge of the technician who's done the semen report by looking at the morphology. And if he has an idea, maybe he's not being able to identify the normal sperms. It is very difficult when they write 1 to 2% normal. Maybe that patient may have 5 or 6% normal. Yeah, when they write all abnormal, then it is very important for some senior embryologist or technician to see whether all the sperms are abnormal or not. So, especially when they have a globospermia, where all the sperms have no head, no acrosome present on the head. So that type of abnormality anyone can see. But saying that 2% is normal, 3% is normal, 6% is normal is quite difficult. So don't discard a man for normal conception or IUI only because it says that less than 4% is normal. But there are some normal sperms. Now, this is another very sad scenario when a man comes very disturbed. You see the man with the report, but you don't see how he got disturbed when he got the report first time, which shows azoospermia, and how to evaluate this semen analysis report. So, if there are no sperms in the semen analysis, please repeat it 3 weeks apart. Take a detailed history of any illness, radiotherapy, cancer, anything in the past, or any surgery like inguinal hernia or undescended testes as a child. And then how do you confirm azoospermia? If two semen analysis 3 weeks apart show that there are no sperms, please ask your technician to confirm azoospermia by centrifugation of a semen sample at minimum of 1000 G, which should be approximately about 2050 rounds per minute in a 10 to 15 centimeter centrifuge machine. G is a constant thing, so it is always 1000 G, 15 minutes, and then the pellet which is there, that needs to be seen in a high powered microscope. So just understand, G is the symbol written for RGF, or relative gravitational force. This remains constant. If the centrifuge becomes bigger, so similarly, the rounds will become less. If the centrifuge becomes smaller in diameter, it will have to rotate many more times. So RPM will change, but G remains the same. And this is how you ask your technician or whichever laboratory is doing that, please centrifuge the semen sample at 1000 Gs for 15 minutes. Look at the pellet and tell me if there are sperms or not. Suppose you've seen that there is azo also, and the semen volume is very little. You just read that normal semen volume was 1.4 ml. Now, you see that there's hardly, they've written 1 ml or 0.5 ml. What do you think? That what is the problem? So first thing you will think is that maybe improper collection or spillage of the sample. So ask the patient, did you spill? Did you not collect the whole semen sample? Or maybe the man was severely dehydrated when he gave to give the sample, or he's ejaculating, masturbating too frequently. Another important thing is retrograde ejaculation, and very commonly happens in middle-aged men, say over 35, even under, especially if they are obese, diabetic, or they have diseases like autoimmune disease like multiple sclerosis or spinal cord injuries, anything, medications with alpha blockers for hypertension also. What happens normally, the bladder neck closes as one ejaculates and the whole semen flows through the urethra out into the external. But if the bladder neck is open, then during orgasm, the ejaculate takes the least part of resistance into the bladder. And here, if you test the urine, you may find sperms. There are different ways to do it, how you collect and all, but this is the answer for this. Then hypogonadotropic hypogonadism. Lack of testosterone fails to stimulate the prostate and seminal vesicles and the testes to produce fluid and sperms both. And here you do estimation of gonadotropins, the FSH elite, and you would know that this condition is there. Ejaculatory duct obstruction, it prevents fluid from the seminal vesicles. Now 70% of the semen volume comes from the seminal vesicles. So if there is any infection, cyst, obstruction, partial or full, the volume is the first thing to go down. Ejaculate of the pH will go towards the acidic side, maybe less than 7.2, still alkaline, and there would be no fructose. So in the semen analysis report of WHO, I did not show you fructose, but this is very important parameter which you will find in most semen analysis, fructose present or absent. If fructose is absent, think of there is a seminal vesicle obstruction, vasculitis, or something. And last is congenital absence of the vas deferens, CBAVD. It is consistent with very low volume of semen, acidic pH, and absence of fructose also. So any obstruction, whether it is congenital absence of vas deferens or ejaculatory duct obstruction, will have absent fructose, low volume, and a low pH also. So this is how you think of things, and you can direct the patient to a proper specialist to treat this. Case 5, in which case would you suggest donor insemination? Now, we as gynecologists, ART specialists would think of doing a lot of things to be able to get male gametes. But in which cases do you suggest donor insemination without attempting surgical sperm retrieval from the testes? So, affordability for IVF ICSI, undescended testes, high serum FSH levels, and testicular volume. Now, I want you all to think, what are the indications where you would say, okay, I would go for donor insemination? Is the first one there? The second one, third, or fourth? Well, I will answer this question for you. If the patient can't afford, just don't go for sperm retrieval, even if you can retrieve sperms. They can't afford IVF ICSI, you can counsel them for donor insemination and do a donor insemination. Don't get disappointed after 2 or 3 inseminations. Please do more. If her tubes are open, she will get pregnant. But then the question of high serum FSH levels and testicular volume. Once upon a time, we used to think that high serum FSH levels and very low testicular volumes also will require donor. But now, in 2008 also, it was seen that if there is non-obstructive azoospermia, that means testicular azoospermia. There's no obstruction, but the testes is failing. Microtessi and ICSI is done. 4 groups, FSH less than 15, 15 to 30, 31 to 45, and more than 45. Sperm retrieval rates with FSH values in all 4 groups were very good. Clinical pregnancy rates and live birth rates were also very good, if you see. I don't think we can think of better pregnancy rates and live birth rates. So now it is known that chances of sperm retrieval using microtessi is similar for men with elevated FSH level than for men with lower FSH levels. So now this is, I showed you 2008, and this we come to 2025. Did I write from where I took this? This is 2025 statement. Microtessi is highly successful. There's no upper limit of FSH and there's no lower limit for testicular volume to rule out successful sperm retrieval with microtessi. So severe testicular atrophy also, microtessi can retrieve sperms, but the person andrologist must know how to recognize a good tubule. The only thing is where it is fully unsuccessful if there's complete Y chromosome deletion of A, ZF, A or B. So A, B deleted, tell them no, nothing can be done. You will have to go for donor insemination. But if there is deletion of AZFC, then one can try Tessie. We have done it and we got good sperms, and well, the patient did get pregnant, but she aborted, so I wouldn't say much. Testicular histology, if shows hypospermatogenesis, you will have a very high chance that you will be able to retrieve sperms. So, you don't do anything, just look at the 2 indications where they can't afford or the testes is undescended and say, okay, I will do a donor insemination for you. Apart from that, refer them to a IVF center who can send their patients to a urologist, because this has to be done in conjunction. Because if the urologist takes out sperm, they have to be stored and not just tested. So having said that, case 6 is normal female with mild oats in male factor. On examination of male factor, varicocele demonstrated by ultrasound only on coughing. What is to be done? Now, what does World Health Organization say? Clinical varicocele is diagnosis of varicocele by physical examination, by scrotal palpation in upright position during a Valseva maneuver or even without it. So if you can palpate a varicocele, that's a clinical one. What is a subclinical varicocele? Non-palpable enlargement of venous plexus of the spermatic cord, which can only be diagnosed by imaging techniques. You put ultrasound there, all the vessels are lying quietly, nicely, you don't palpate anything. And the moment you ask the patient to do a Valsalva maneuver or cough, you will find that the spermatic cord is suddenly become engorged. So guidelines for varicocele surgery are, please understand, you have to know this because there is a tendency of all urologists who see the patient say that varicocele surgery should be done whenever they see a clinical or subclinical varicocele. But surgery is only recommended if there is clinical varicocele, which is palpable on a physical examination, that is grade 2 or 3. And for subclinical varicocele, surgery is not recommended. So subclinical varicocele is only detected by ultrasound and no surgical repair is recommended. Remember, help your patients by not pushing them to surgery because you did not know whether they should have a varicocelectomy or not. Case 7, is there any role of empirical treatment with antioxidants in males with suboptimal semen parameters? Now, commonly used antioxidants are vitamin E, omega-3 fatty acids, L-carnitine 3 milligram per day, or L-acetyl-carnitine 3 grams, grams a day, levocarnitine 2 grams, plus L-acetyl-carnitine 1 gram, coenzyme Q10, ascorbic acid, zinc, selenium, pentoxyphylline, and ethylcysteine and N-ethylcysteine. Now, all these have a cost, and when you look at products like Xoza or other combination drugs where 2, 3, 4 of these antioxidants are mixed, they are extremely expensive. Do you really think that giving a patient a treatment for 10,000 a month with antioxidants, if it doesn't help, are you justifying? Because if we look at the data, this is antioxidant intervention were given a daily supplement in tablet form containing 500 milligram vitamin C, 2000 IU of vitamin D3, 400 IU of vitamin E, 1 milligram folic acid, 20 milligram zinc, and 200 microgram selenium with 1000 milligram of L-carnitine. This is US clinical trial of 174 couples. This antioxidant formulation was given for a minimum of 3 months. There was no effect on sperm concentration, motility, or morphology, or the rate of DNA fragmentation, which was presented in Esri, Barcelona, Spain. So, finally, antioxidants do not appear to improve semen parameters or DNA fragmentation amongst men with male factor infertility. So, please understand that you have to understand one thing. A sperm cycle is almost of 74 to 80 days. Now, this, and it's not a straight line. It'll go down, the nadir, the curve will go up and then again will go down. Suppose you've used antioxidant for a month and a half when the spermatogenesis is going on the higher side, you will get better sperms and you will think the antioxidants have done the trick. But if you give it when it's going down, then it becomes in the thought of the person, I took this medicine and my sperm count decreased, whereas this is a natural elevation and natural decline in semen counts depending on spermatogenesis, how it happens over 74 days. So it is not the action of this. So oxidative stress is there, and who has more oxidative stress? If there is male accessory gland infection, prolonged stasis of spermatozoa in the epidermis or in the transit, abnormal spermatozoa, systemic pathologies, diabetes, cancer, infections, varicocele, environmental drugs, smoking, pollution, alcohol, all this lead to spermatozoal dysfunction, infertility, and we think that, antioxidant supplementation might help. But it is very important to avoid factors which promote ROS gene formation. Now, I'll just give you a summary of severe oats or azoospermia, what a gynecologist can treat. So I'm going to reiterate on medical management because when it comes to surgery, it is the urologist. When it comes to ART, it is the IVF specialist. So medical management, there is a specific therapy, may help therapy, and non-specific therapy. Specific therapy can be in hypogonadotropic hypogonadism. If you have the ability of doing just a FSH, LH, and estradiol on any day of the cycle and you find it really low, around 1 or 2 MIU, and the estradiol also low, you diagnose this. The best treatment is give them treatment for 6 months to 9 months. Be confident, start with HCG, go on to FSH, you will never be wrong. HCG has to be given in doses of 2000 IU, every third day, matlab 2 days gap and an injection, 2 days gap and an injection. And when you first give HCG priming for 2 months or maybe a little more, then you start FSH every alternate day, 150 units. It will work. And don't think that so many injections today, subcutaneous injection are freely available, pens are freely available, and people who are diabetics take insulin 2 times, 3 times a day all their lives. What is the problem for these men to take these injections for 6, 8, 9 months? And if they can take the injection and after every 3 months you find that there is improvement, the sperms have started appearing in the semen, or the testosterone value is going up, then you know what you were trying to do is working. Number two, what you can treat is genitourinary infections. May help therapies, possibly aromatase inhibitors, which is an off-label drug for very obese men, and antioxidants if you find the reactive oxygen species high. We don't do these tests very frequently, but if the person is diabetic, is a smoker, then maybe antioxidants may have a role. And non-specific is again idiopathic oats, and you can give non-empirical treatment, whatever comes to one's mind gives that. But I do not recommend treating this. But yes, treating this is very important. Treating this might help. So when we say hypogonadotropic hypogonadism, it's small testes, azoospermia, and shaving frequency is less. Low FSH, LH, testosterone causes, well, HCG 15,000 to 2,000, 2 to 3 times a week for 3 months, then FSH 75 to 150 alternate day for 6 to 24 months. And you see what happens. The mean total testosterone from 41 went up to 647. The combined testicular volume from 24 cc went up to 33, and mean sperm count from azoospermia went up to 36 million. So this doesn't happen with every patient, but you have to have patience and confidence both. If you lose confidence, the patient will not be able to have confidence on your treatment. If there's infection of the genitourinary tract area, which is prostate, seminal vesicle, or maybe orchitis, it is known as MAGI, male accessory gland infection. There could be asymptomatic patients who are diagnosed on leukocytospermia. Now, here, if you write more than 1 million pus cells means nothing. They have to undergo a peroxidase test, and only if they are positive on the peroxidase test, then they are leukocytes. Otherwise, they are immature spermatocytes which are there and don't indicate any infection. Now, if you want, you can treat these infections. If you want, you can refer these to the urologist. But remember that asymptomatic patients are rare. It is mainly patients who've had pain during erection, ejaculation, urination, or if you, I mean, we don't even examine our male patients, but if they have tenderness or orchidal tenderness or tenderness of the prostate, then you know that there is true infection. In addition to alteration of the basic semen parameters, sperm function and DNA integrity may be affected by chronic inflammation of the male genital tract. So this you can treat or you refer it to a urologist. Antimicrobial therapy has to be given if there are more than 1 million peroxidase positive WBCs. Fluoroquinolones are the most favored drugs. Levofloxacin 500 milligram daily for almost 6 weeks is important. This infection only eradicates microorganisms but cannot reverse functional deficits, or if there are adhesions which have formed or there is a chronic inflammatory effect on the epithelial cell and the secretory function, we cannot change that in the long term. So the faster the treatment starts and the earlier it is caught and given helps. But then if you feel that you're not confident, you can refer these patients to a urologist. Obesity is a risk factor for male infertility, and we all understand that peripheral androgen aromatization is enhanced in men with elevated BMI because they have high serum estradiol and low testosterone levels. Why does this happen? Because there is aromatase inhibitor, which is there lots in fat, and that aromatase inhibitor changes all the testosterone into estrogen, and these men start having dysfunction of sexual performance, means erectile and ejaculatory dysfunction, and then the semen count goes down, the FSH level goes down, the testosterone levels go down. So aromatase inhibitors for obesity-related male infertility should only be dealt by a specialist. This is off-label use, may have its own side effects. Anastrozole is 1 milligram alternate day. Letrozole has been used as much as 2.5 milligram once daily to even once weekly for 6 months, and has shown results in terms of the testosterone estrogen ratio, the ejaculate volume, and the sperm concentration all. So it could stimulate sperm production. Why? Because it stops the testosterone conversion into estrogen. Estrogen levels go down, testosterone levels go up, and as testosterone levels go up, sperm production increases. Now, when to refer to a urologist? If you find that there is grade 2 or 3 varicocele, if you are able to examine your patient. But if you don't, and you find that on ultrasound also they write that this is grade 2 or 3 or varicocele, please refer them to a good urologist who can do varicocelectomy. But this should be for a young wife and a young husband. If already the wife is plus 36 or 37, it is better to think of other options. Reversal of sterilization, which is done quite rarely these days. People sort of go for PISA rather than reversal of sterilization, but then yes, this is one surgery. And Maggie, if it is confirmed, if it's symptomatic or suspected asymptomatic, both should go to a urologist if you have doubt in the diagnosis. When to refer to ART specialist? Azoospermia with high FSH and small testicles. And we normally do not send our patients if the volume of the testes is less than 2.5 cc each side. But then if they benefit, it is only micro TESA and not by normal TESI, which we do just by a needle to pull out a tubule and see. Then azoospermia with absence of vas deferens bilaterally. No improvement after 6 to 12 months of medical treatment for either obesity and infection-related oats or azoospermia. Severe to moderate oats or idiopathic azoospermia. Idiopathic means FSH level is normal, testosterone level is normal, but there is azoospermia. And you have put them on oral antioxidants for 3 to 6 months with no benefit. I would want to cut off this oral antioxidants, but maybe this just gives them time, a chance to buy time. And maybe in those 3 months, if the spermatogenesis is going to increase, it might increase. The credit may go to the antioxidant, I don't care, but if there is a chance for semen to become better, it will become better. Now, I'm going to put a quiz for everyone. I don't know how we would be having answers. I think there is a chat box. Is there a chat box?
Yes, ma'am. Chat box is there.
Okay, there is a chat box. Now, I would want in this chat box if everyone could write their answers, and it would be great for me if I could. How can I cross over this chat box? I just opened it and it's sitting right in the middle of my presentation. Let me see how I can get it off from here. Okay. Okay. So do you know what to do in the following situations? All of you, please be attentive and answer. I'll be very happy if even 20% answer this. Question 1. The ideal abstinence before semen testing done. 1, 2, 3, 4. Which one is the correct answer? Please put it in the chat box. What do you think is correct answer? As per WHO. Then next question, should I come to the next question? Have you answered? Okay. Normal semen analysis 2021. 60 million, more than 30% normal. 20 million, more than 14% normal. 15 million count, 4% normal morphology, and 32% progressive motile sperms. And 16 million count, more than 4% normal morphology, and 30% progressive motile sperms. Which one is the correct answer? Please put. I'm very glad to see I've got almost 60 answers in the chat box. which one is the correct answer? 16 million or 15 million, 30% or 32%? This is 2021. Then I have two more questions for all of you. What is the best medicine to try in very obese men with low sperm count? I'm sure you will know this. And 1, 2, 3, 4. This is interesting also because you can try this medicine, but headache is the most common side effect. And if it has, you have to lower the dose. And the last one is male partner has subclinical varicocele on ultrasound only with low sperm count and motility. What would be your treatment? Varicocelectomy, antioxidants, no treatment, or letrozole? So these are four important questions. The questions are not over. I still have one more brain teaser. So once you've answered this, we'll go to the brain teaser. Has everyone been able to answer? Okay. Now, some more brain teasers for you. Come on. This is, can you find all 5 Ys hidden in this image? You just have to tell the lines where the Ys are there. I'll give you 1 minute for this. You just write the lines and that should be good for me. 5 Ys are hidden in this image. Half a minute gone. Forty-five seconds gone. Okay, these are the 5 Ys you'll find here. You all know how many you had been able to tick. So in line 2, line 5, line 8, 9, and 11. In all these lines, you find a Y. Anyways, thank you so much for letting me speak and with best wishes.
Thank you, ma'am. That was wonderful. You covered everything. Now everyone is so confident to treat male infertility. Dr. Vidya, any comments? And
Yeah, Dr. Shilpa, could Madam give the answers for the quiz questions?
yes,
Okay.
ma'am.
Okay, this is, I'll just do that. Give me 1 second. Okay.
Yes.
Okay, the first one is 2 to 7 days, WHO. Number 3.
Yes, ma'am.
Then number 2, normal semen analysis is the last one. 16 million count, 4% more than 4 normal morphology, 30% progressive motile sperms. Am I right or am I wrong? I need to go back to the WHO. Anyone who
No.
You're
challenges this,
correct,
then
ma'am.
go back. Correct. Okay, thank you. And then comes this one, best medicine to try is only anastrozole or letrozole.
Yes, ma'am.
And the last one is subclinical varicocele, no treatment.
No treatment.
Right? So, no unnecessary medicines to either men or women. We take a pledge that we are relying too much on antioxidants. Even the IVF specialists, I've seen 5 antioxidants written. And when I ask the prices for this, each tablet is 12 rupees or 20 rupees. And I think, how are these people draining so much money on the hope that something good will happen? So use sparingly antioxidants. If you want to use the cheaper ones. And I did give you a list of cheaper antioxidants. I like to use vitamin E with vitamin C a lot, especially if the semen is very alkaline. Where did I give? Just before this. Here.
Thank you, Dr. Abha. That was a brilliant presentation, and especially it made it interesting to have the quiz and also the brain teasers to find the why. So
Yeah.
it just alerted everybody, and I think the presentation was excellent.
Thank you. I can
Thank you.
stop sharing. Has it stopped sharing or it is still there?
Stopped it.
Stopped, okay. So it's done. I want to see these 99 chats. It's so interesting to see so many answers in the chat box.
Ma'am, there are some questions. Some questions.
Okay, right.
Ma'am, one person is asking
Your voice is
about
cutting off. I'm sorry.
FSH male infertility check and also before micro TC.
I couldn't hear you.
Somebody was checking about
Ah.
FSH before micro TC, of FSH
We
injection before
always
micro TC.
FSH injections before microtessie. See, why does
Yeah.
why is FSH 45 in women and why is FSH 45 in men? When so much of FSH pituitary is throwing out and yet it is not being able to make sperms or it is not being able to develop an egg for ovulation. You understand? So adding FSH, why? How will it help? I don't understand. Can you understand the logic? Say a woman has 45 FSH on 2 occasions. You'll say that she's got POI, right?
No, ma'am, they are asking before micro TC.
But before microtessie, you give more FSH. Already the FSH is so high. How will that help? Maybe testosterone could help. Maybe letrozole could help, which increases testosterone concentration. I think that is the only thing before microtessie which can help. Testosterone, which will suppress FSH surely, but testosterone, if it is low, giving testosterone or maybe giving letrozole also has been the last paper which I showed was in not obese men. It was on oligospermic men where they used letrozole and they found better counts. So I think these two drugs can help, maybe clomiphene to some extent, but not FSH. Gynae ke paas, these questions won't come. The gynecologist will straight away throw them away to the ART specialist. You go there. And as ART specialist, I feel that if FSH is very high and testes are very small, even microtessie in our hospital does not give us sperms. Dose of letrozole has to be very individualized. It is 2.5 milligram, as little as 2.5 milligram once a week to 2.5 milligram daily. But you can look into the symptoms of the man. You can look at the testosterone level, the estrogen level. And if you find that there is an increase, continue the same dose. Otherwise, reduce it. Severe
So
roads, yeah,
somebody
you
is
can give HCG, might help HCG, but all these are again empirical. The best is refer them to the urologist for a microtessie, and if he can find sperms for you, which you can use in ART, that is all what we need.
somebody is asking poor ovarian reserve. What is the ovarian stimulation drugs? Dr. Supriya Sonawala is asking.
Yeah, we'll have to take another lecture on ovarian reserve. But ovarian stimulation drugs in poor ovarian reserve are the same as you would give for a normal ovarian. She's still ovulating.
City clinic, cesarean call bantrippa. Al Pratima Uragina, Shashuma is in lifeline duty. Only 3 of us cover. I had to go.
Yeah, can we leave? I think there are a lot of people who are wanting to go. Thank you so much for inviting me over, Vidya. I don't know, I can't see anyone. Now I can see.
I think the-
Yeah, Dr. Shilpa, please propose the vote of thanks.
Madam, I
Hello.
think you've covered all the questions. Thanks a lot for accepting our invitation. We look forward for more sessions from you.
Sure.
Okay.
I just
Shri
thought we'll
ma'am,
have
Dr.
some
Shobha Guri
questions
ma'am,
for every.
our Kasoga entire team for giving us an opportunity to conduct program and Dr. Madam to accept our invitation and give this wonderful session. People who have logged in. I think I would like to extend my thanks to all the delegates who have logged in. It was a very, very useful session. Thank you, ma'am.
You're welcome. And I'm glad that I spoke because it also cleared a lot of my doubts. Good night.
Good night, ma'am.